be familiar with the terms in the setting before surgery, when you give neoadjuvant therapy, how does that affect patient outcomes? What are the ongoing trials for it? And then I was going to show you a brief video of operating after neoadjuvant therapy. Unfortunately, it doesn't seem to be working. And then go over the outcomes of neoadjuvant, of patient undergone surgery. One more. So, smoking and pollutions are the #1 killer. They're silent killers of lung damage, and they result in up to 30% of deaths according to the WHO records as of 2019. They also lead to stroke, heart disease, and other lung disease. If we can get rid of those two factors, we can really impact the outcome of lung cancer patients. Next. As a result, 31st May has been declared as the National Tobacco Day, and that is one day that we are trying to see if we can eradicate smoking completely to have healthy lungs. Next. Going into the talk more so about immunotherapy. So traditionally, immunotherapy was used as first-line therapy for metastatic patients who were never candidates for any surgery, as consolidation therapy following chemotherapy and radiation in patients who had unresectable disease, and what we call as adjuvant therapy, meaning after surgery, if you had any risk factors to have a high recurrence, you would get adjuvant therapy. However, given success in treating advanced cancers, there's been a recent interest in immunotherapy in the neoadjuvant setting, in the preoperative setting. In patients who are EGFR and ALK negative, those are biologic factors, regardless of their ligand status, they would get immunotherapy. And previously, it has now become very apparent that some unresectable tumors that had recurrence after complete radiologic response. Next. Current immunotherapy agents are focused on these two pathways, and I'll go into these pathways in the next couple of slides. Next. So going back to Immunology 101, whenever a tumor cell has been recognized by an antigen-presenting cell, they will pick up the tumor-associated antigens and then bind with the MHC complex and on the T cell receptor, and then they'll activate a T cell cascade, thus resulting in development of effector cells. As these effector cells form, CTLA4 is another ligand that starts to get expressed on this T cells, which then binds to CD80 or B7 ligand on the antigen-presenting cells, and that actually suppresses the immune system. So those are co-stimulatory and inhibitory signals that will get activated at the same time so that a patient doesn't mount a significant cascade immune response. These are sorts of inside checks and balances within our body. Once the cells become differentiated into effector cells, they migrate into the tumor tissue, and something else happens. Now the effector T cells will start producing PD-1, and tumor cells tend to produce this PDL ligand, which then binds to the T cells and inhibits yet again another negative inhibitory signal so that the patient's immune response gets blunted. Next. Thank you. So again, CTLA4 expressed on the T cell binds to this B71 or CD80 complex on the antigen-presenting cell as a negative inhibitory signal, and PD-1 expressed on the T cells binds to PDL1 ligand on the tumor cells, and it acts as a negative inhibitory signal. So if there was any way to block these two pathways such that this immune suppression doesn't happen, you could make someone's immune response better. And that's the whole concept behind immunotherapy and why it works. So up until now, like I said, patients who were mainly stage 4 disease or stage 3 disease that were not candidates for surgery because the tumor is unresectable, they were offered PD-L1. However, now there's a huge focus on patients who are early stage tumors or even resectable stage 3 tumors, where you can offer them immunotherapy and they may have a better outcome in the end, is what we've seen. Why do I say that? There's a number of trials that are running internationally. However, Checkmate 816 is the one trial that's the closest to having some sort of results. You can see all these trials are focused on neoadjuvant chemotherapy or neoadjuvant immunotherapy, and all of them have yet to complete. However, Checkmate 816 released its results, its interim results last year. Here's what they found. This is a busy slide, I get it, but this is the main focus of this talk. It was a randomized multi-institutional phase 3 trial. They took 179 patients in 2 arms, patients who were early stage tumors, so resectable 1B to 3A. They were randomized to either a neoadjuvant immunotherapy arm along with chemotherapy, or the conventional treatment of just chemotherapy alone. And then these patients had surgery within 6 weeks post completion of their therapy, and then went on to optional adjuvant therapy if they had residual tumor or very high grade tumor where they would benefit. The primary endpoints of the studies were 2 main things. PCR stands for pathologic complete response, meaning how many of the patients who were treated with immunotherapy versus chemotherapy had a complete response, where they removed the tumor and they found no viable tumor, which would be a great thing for the patient. And how they affected event-free survival, meaning the number of recurrences. Did the immunotherapy upfront make a difference on having a decreased recurrence? The secondary endpoints were overall survival, and MPRs made the major pathologic response. Surprisingly, the neoadjuvant nivolumab plus chemotherapy, which is immunotherapy plus chemotherapy, had a whopping 24% pathologic complete response versus a measly 2% pathologic complete response with chemotherapy alone, with an odds ratio of almost 14. When they looked at stage-by-stage analysis, what they found was patients who had, for every stage, you can see that patients had more complete response in the immunotherapy arm versus just the chemotherapy arm. What that means is when you look at lung burn coma, so these are 2 graphs, lobectomy and pneumonectomy. Lobectomy meaning you just take out one lobe of the lung. Pneumonectomy means you have to take out the entire lung based on the size of the tumor. If you compared more patients in the blue arm, which is the immunotherapy arm, actually underwent lobectomy versus more patients who had just the chemotherapy underwent pneumonectomy. What that means is that you could spare more lung burn on these patients so that they can breathe better. Can you go to the next slide? I think it's squeezed again. So when you looked at the median event-free survival, meaning recurrences in the patients, nivolumab plus chemotherapy, meaning the immunotherapy arm, had 31 months before having a recurrence, versus patient who had the chemotherapy alone had 21 months before having an event-free recurrence. So obviously, every way neoadjuvant immunotherapy is faring out better. What about pulmonary resection after neoadjuvant immunotherapy? Now, a lot of surgeons were afraid when immunotherapy came out because we don't know how much fibrosis they will have. Will they have intraoperative bleeding complications? Will the lung vessels will be too friable? Because when we divide the lungs for these cancers, you have to divide the artery, the vein, and the airway to every lobe, every structure that you're doing. So anytime you're dissecting one of those vessels after neoadjuvant chemotherapy, immunotherapy, as a surgeon, you're always nervous. Are you going to harm the patient and help the patient? Will you get into bleeding that you can't control, and will you lose that patient on the table? So multiple studies have come out since then, and you can see the numbers are small. On every study where they've said these patients underwent neoadjuvant immunotherapy and underwent resection, but it shows that it's possible. Like I said, there are limited studies on the perioperative outcomes after immunotherapy. However, they report that there's a 20% rate of conversion rate to open. So if you're trying to do it minimally invasively with thoracoscopic cameras and the robot, there's a chance because of the scarring and because of friable tissue, you may have to convert to open up to half the time. Then there's no difference in complete resection rates in patients who had any immunotherapy versus just chemotherapy alone. And there's no clear timing that we've resolved. When should you operate after immunotherapy? Can you operate after 2 weeks? Can you operate after 6 weeks? When is the fibrosis too extensive for you to operate? Having said that, overall there's been no incidence of evidence of any increased morbidity and mortality with neoadjuvant immunotherapy compared to chemotherapy alone. Going back to the Checkmate 816 trial, they said that 83% of the patients who had immunochemotherapy underwent surgery, while only 75% of those patients who underwent chemo underwent surgery. And the surgery was canceled because of for various reasons. 15% of the times in the immunochemo arm and 20% times in the chemo arm. The cancellations were for disease progression, less so in immunotherapy arm. More disease progression happened in patients who had the chemotherapy alone, and adverse events where the p-value was insignificant for both immunotherapy and chemotherapy arm. In the end, this paper concluded that there is no difference in overall adverse events or delays in surgery between the groups with either treatment. This was the video I was going to show, and I was going to show, this is a patient of mine who had both immunotherapy and chemotherapy before surgery. And yes, there's a little bit more scar tissue, there's more fibrosis and peeling off this vessel. So this is a pulmonary vein. I'm sorry if somebody feels that they can't see this, then you can just close your eyes for a few minutes. Behind the pulmonary vein is a pulmonary artery that goes, and the very posterior structure is the bronchus that you end up dividing. And usually that's when you encounter the most scar tissue is around the airway, when you have to do the division from and separate one lobe from the other. It was a very nice video. I wish it would have played. So last year they published this meta-analysis. It's a systematic review of almost 16 studies. It's a busy slide. It has almost 1,000 patients in the study, and what they demonstrated was that every time the patient had immunochemotherapy plus chemotherapy, the major pathologic response rates and PathCR rates were higher than in patients who just had the mono immunotherapy arm. So we have now seen that even single agent immunotherapy is not the best option. You should get immuno and chemotherapy. They have the best outcomes. Next. And on their, in this systematic review, they showed that when they looked at the pooled data, about 43% patients had major pathological response rates and PathCR of 22%. But you can see in the bottom slides, part of the slide, that every single time the immunochemo arm did better than this monoimmunotherapy. So in summary, immune checkpoint blockade, the process of immunotherapy, has pushed the limits of where we can take lung cancer and how we can operate on patients who were once deemed unresectable, but now we can operate on them because of the major pathologic response. You can spare as much more lung parenchyma as we could ever fathom. And there is much role of what's called tumor mutational burden, circulating DNA cells, to determine whether or not we can predict which patients will respond better to immunotherapy versus not. That's a whole word that's unexplored. I always like to end my talk by saying, what's the future for us? What can we do next to even go farther than where we've been today? Thank you. I'll be happy to take any questions.
Thank you, Doctor. Very interesting. Anybody got any questions in the room? Oh, I can tell you all. I've got one. I thought they were all asleep from food. I thought they were all, post.
Is there any case resistant to immunotherapy in the lung cancer?
There are patients who will not respond well to immunotherapy. Now, there has been a lot of reports where they looked at PD-L1 status, the ligand status. And at first we used to say patients who are PD-L1 0, meaning they don't express any PDL ligand on their tumor cells, will they ever respond to immunotherapy? We've actually found out we are wrong. They will respond to immunotherapy. There's a fraction of patients that somehow still respond. Why? There's no clear evidence for why. There's something called an abscopal effect. Abscopal effect means that if you get immunotherapy, somehow your immune system mounts a higher response at the tumor site. So when you hit them with radiation at that site, they actually have a better response. There's something about the tumor and having immunotherapy on board which makes them more radiosensitive when they were not. So very interesting question. Yes, we have not found why.
Is it possible to increase the PD-L1 ligand in the tumor cells?
That's a great question. I don't think that's been explored yet. Maybe that our next Nobel Prize winner will explore that question.
Thank you so much.
Thank you.
Thank you again, Dr. Puja. Now this is where I have to get